Welcome everyone. Also from my side, I'm really excited to announce for the last webinar of this year, entering the era of personalized sarcoma advancements and horizons. And we have 4 speakers tonight, which will hopefully show us the future. We all say that AI will disrupt the future, how we practice medicine. And we have to know how this will be the case. And we want to build a bridge. And specifically in this forum, where we have the opportunity to discuss on a global forum, we want to take advantage. And I'm really very happy that tonight we have on the hand from the University of Utrecht talking about the promises and pitfalls of AI prediction algorithms. Followed by Henock Yebyo from the University of Zurich, talking about benefit-harm modeling. And then Lucia Petito from Chicago, talking about target trial emulations. And finally, Philipp Heesen, talking about how to assess precision care data. I'm really excited, and without losing any further words, I would like to give the word to On de Hand, for the first talk. Please, on.
Yes, thank you so much for the kind introduction. And I am very happy to be here and excited to share my work with you. Yes, okay, let's dive in. So I am Anne de Hond from the Netherlands. I'm an assistant professor at the Julius Center at the University Medical Center in Utrecht. And my research focuses on the responsible development, validation, and implementation of artificial intelligence. So incredibly relevant for this talk today. And I like to focus on both the promise of this technology and the pitfalls of this technology. So what can it bring us, and how do we have to be cautious when trying to develop and apply this? Right, so with no further ado, I will present you with some hopefully tantalizing use cases that make you excited. And then I will address 3 specific topics that I think deserve more attention when bringing these techniques to clinical practice. Diving in with the promise of AI, I think we really have to start here with acknowledging the fact that artificial intelligence is everywhere. We tend to interact with this technology on a daily basis, be it in smartphone applications or smart assistants, or in fact, ChatGPT, that I think by now most people will have had some experience with. But very interestingly, we see this promise not really being translated to the healthcare fields. So for whatever reason, there is not the same effect of implementation and use within healthcare. Now we can debate if this is a bad thing, or maybe healthcare is okay as it is. But I would like to make the case for the fact that healthcare is facing tremendous challenges, and AI can be a promising technology to face this. So specifically, I am talking about the rising of everything. So healthcare costs. I pulled the costs for Switzerland for this talk, rising healthcare costs across the Western world, but also rising healthcare complexity that goes along with our aging populations, and very importantly, rising healthcare burden. So we see an increase of burnout as well among these healthcare professionals. And AI, of all techniques, has the potential to, for example, automate certain processes to make healthcare more efficient, but also lower the burden of care, and also help with complex decision making. So it has a lot going for it. It's just not being implemented yet. And to give you a specific example of what this technology can do for us, I had to pull a ChatGPT example. I really feel obliged because it's so omnipresent right now. And so in this ChatGPT example, researchers investigated how it could answer patient questions. So how it could help with the communication between physicians and patients. in this specific case, the chatbot was asked to give advice about bleach being splashed into an eye, and they also provided the physician response for this question. So first we see the physician response. It is matter-of-factly, it is to the point, it's correct, and it provides some further actions. And then we see the chatbot response, which is a lot longer. And I specifically enjoy zooming in on the first sentences of these responses. So our physician response is very to the point, sounds like you will be fine, do not worry too much. And the chatbot response is much more empathetic. It says, I'm sorry to hear that you got bleach splashed into your eye, blah, 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 blah. And that's exactly what these researchers found as well when analyzing the results of many responses. They first found that this chatbot was on average really accurate, a little bit more accurate even than the physicians, but it also found that this chatbot was more empathetic, which is, I think, the most shocking revelation, because I never anticipated that AI could really take over some of these very human components of healthcare. Now, I think this makes a smashing case for AI, with the very important side note that this is an easy illustration, right? So it's a quick illustration of a potential use case, but this specific use case has not been tried and tested enough to really say something about clinical safety, clinical effectiveness. But hopefully it does get you into the mood and the idea of what this technology can do. And for the second example, I wanted to pull a project that I have been working on in the Leiden hospital. It is a prediction model that aims to predict hospital admission at the emergency department. And the very real use case for this specific algorithm is overcrowding at emergency departments. So what we also tend to see across the Western world is overcrowding. I actually would say across the world is overcrowding at emergency departments. Overcrowding means that the queues rise exponentially and people really have to wait for a very long time to see a physician or to go to a next treatment or a next stage in the treatment. And this has very negative consequences, both for patient care and for physician burden again. So it would be really good if we can bring down this crowding in any way, shape, or form. And together with emergency department physicians, we worked on this idea of bringing the decision to admit a patient to the hospital forward in the decision process. So generally, this decision will be made at the very end of a patient journey through the ED, but we anticipated that with the help of a decision support tool, we can make this decision much earlier, because usually you tend to know if a patient will be admitted already in the early stages, or at least you will know this for a large proportion of the patients. And knowing that this decision will be made can really help us already speed up some of the processes that can delay patient admission in the later stages, like informing next of kin, getting a medication list, and informing the next department. So the admitting department that there needs to be a bed, a treating physician, etc. So it's a very logistic problem that I think holds a lot of promise for this type of application. And we're currently testing this in a clinical setting. So this has been implemented and we're trying to see how clinically effective this tool really is. So two quite different use cases. We've got the promise of chatbots, ChatGPT on the one hand, and then the promise of these prognostic models on the other hand that have been around for a while. And hopefully that gives you at least a flavor or a taste of what these technologies can bring us, how they can automate certain processes, how they can jump in situations where physicians or clinicians tend to be overburdened. So that is really, really exciting. And of course, very interesting field to be in. But then we move on to the second part of my message, and that is the pitfalls. So we know that these techniques do not reach clinical practice to the extent that we might want them to. And I think part of the reason is that there are these pitfalls that really need to be addressed before these techniques can be safely used and adopted in clinical practice. And I have pulled out 3 that I have been working on and that I think deserve specific attention when we look at this topic. So starting with how to clinically validate a model. With the clinical validation, we really mean the testing of the accuracy and the predictive performance of this model in a setting that is relevant for the clinical use. So usually these models are developed right in a development setting with the data scientist, can be offsite with convenient data, but especially when we move towards clinical practice, we really want to know how these models behave in that setting. And that's exactly what clinical validation can do for us. Now, an additional reason why I think this deserves a lot of attention is because, well, I already talked about few models reaching clinical practice. Some colleagues of mine have come up with this concept of the leaky pipeline. So models simply dropping out towards implementation because there is not enough resources, not enough research being done. And the second stage, where a lot of models tend to sort of perish on the road towards implementation, is validation. And I think that is unjustified because validation is not, clinical validation, it's not necessarily that difficult. You just need to know what you have to do. Right there, you need to follow the step procedure and you need to really know how to do it well. And then I think we can really gain a lot of momentum in doing this well. So a very, very good illustration of why clinical validation is super important is the EPIC sepsis model. Not sure if some of you have heard of this, but in a nutshell, the EPIC sepsis model was developed a couple of years back by EPIC, the healthcare record software provider. And it was a model to recognize sepsis in hospital patients. It was developed in a sort of very concise patient group, just one hospital or a couple of hospitals. And it was also validated. So it was also tested in this setting. And then it was rolled out across the United States. So serving an incredibly varied population. And so a couple of years later, an independent researcher again looked at the performance of this model, but in a much broader sense, so in a different context from where it was developed. And it found that this model missed so many sepsis cases. So the false negative rate of this model was really high. And that is, of course, the worst outcome for a prediction model or an AI model, because we really do not want to miss the positive cases, right? That's the one thing we want to get out. Usually. So this was very concerning and made a very clear case for why we need to focus more on proper validation, contextual validation, which some researchers have also called targeted validation. So it's not sufficient to just test the performance on a model on a readily available data set that just happens to be there. That makes it really easy. But we really want to encourage people to test model performance in the setting in which it will be used, right? And so that might mean that in my case, if I want to develop and use a model at the UMC Utrecht, I might get away with internal validation and then some temporal validation. So just studying this model performance on Utrecht data might be sufficient. But if I then also want to use this model in the rest of the Netherlands and maybe Switzerland, I really do need to expand my scope of validation. So that's just basically what this somehow little bit complex pyramid is trying to get across, is use data, validation data from the setting in which you want to use this model. And then I think we can really, really gain some momentum with safe use of AI. Right, my second pitfall, second point I want to discuss that already is receiving a lot of attention, but it's simply a very difficult point to address, is how to make AI fair. By fair, I mean that we provide equitable outcomes via this algorithm across many socio-demographic groups. So everybody treated equally or equitable. There are many excellent cases for why we need to do this. I think one of the most illustrative examples is the Twitter example, when Twitter was still Twitter. And this specific algorithm used to crop images to that were kind of weirdly shaped. Here we see very long images to a part of the image that it thought would be most interesting and most alluring to the Twitter user. So it could present a cropped version of this image on the Twitter feed. And what people found out is that if they fed it a Republican and a Democratic presidential candidate from the States, it would always crop this image to the white presidential candidate, which happens to be Mitch McConnell here. And this even was the case if they changed lots of things about these images. So for example, they changed the tie color and the facial expressions and the background color, etc. The allocation in the pictures, it's always cropped to the white male candidate. And so there's absolutely no reason this should be happening. At least it should have been random or something. So there is a clear indication that there is some discrimination bias going on in the selection of this algorithm. And we have a very clear equivalent of this problem in a healthcare setting. And this is an algorithm, a commercial algorithm, again in the States, that aim to identify patients most in need of healthcare resources. So it tried to provide a prioritization of patient needs. And what these researchers found when investigating this algorithm is that at any given risk score, the Black patients were considerably sicker than the white patients. Again, this doesn't make any sense because this risk score really should be an indication of the sickness level of these patients. And what these researchers found is that this algorithm used healthcare costs as a proxy for healthcare needs, which in this case is a very biased predictor. Because, for example, in the States, the Black population simply spends less money on healthcare, but this doesn't mean they don't need the healthcare. It's already an allocation problem, which is exacerbated by including this predictor in this way. So definitely some concerning examples. And now I want to quickly go over some points how we can address this problem in our healthcare data. And the main mitigation strategy would be to involve your stakeholders across the development of these models, to kind of pick out these models in an early stage and not after it's been implemented. We can also omit sensitive attributes like race and ethnicity from the modeling procedure. And we can adjust these models to provide more equitable results for different populations. For example, we can do this by developing a separate model for each demographic group of interest. All right, then I want to discuss my last point, my last pitfall, and that is the creation of trust, or saying it in reverse, the lack of trust for clinical users in these models. And how can we generate trust? Now, I've already very explicitly linked this to the idea of explanation, so explainability. And this idea that we need to generate explanations, model explanations to generate trust is really widely spread in the literature at the moment. But I think it is limited, and I do want to address that. So I think it is excellent at gaining trust for certain aspects, but it won't get us all the way. It's not a cure-all. So I also want to address some other ways we can do this. And first, to illustrate how model explanations can really help in this respect is by showing this image classifier. This model AI classifier aims to predict skin cancer for skin photos. And for some of these photos, researchers added purple spots. I'm not entirely sure why they did this, but I think so they know which spot to look at. And so these researchers trained a classifier, an algorithm to predict this. And then they added an explanation layer to show where the algorithm is looking in these pictures. And what we can see here beautifully is that this algorithm is distracted immediately by the purple spots. So it's not looking in the right area when these purple spots are added. This is a great illustration of how this explanation algorithm can help us to catch the errors in the modeling, catch the errors in the classification. So it's really good for error catching. However, it's very limited in providing a full verification of why it reached a certain decision. And that is really well illustrated by this husky example. So we see a photo of a husky. Again, an image classifier was trained on this, and then we added an explanation layer to show where this model is giving its attention to. But we see it provides the same evidence for this picture being a husky as for this picture being a transverse flute. It's looking in the same area. So we don't really get convincing evidence that this is a husky, right? No conclusive evidence. I think that is exactly the problem with these explanation methods. They are very limited. They are great at catching and detecting mistakes, but they cannot guarantee that there are no mistakes. It's very difficult to get the full verification of why this is a husky. And so I think we need some other methods to really generate trust. And a very important method is validation. I already talked about this, but I think showing the performance of a model in your clinical setting is a very foolproof way of gaining trust in its performance. We also want to monitor model outcomes after it has been implemented to make sure it won't start making mistakes at some point. And this is a little bit of a loop or a catch-all, but we need experience with these models. I think that will really help to understand how we need to interact with them, how we need to design them to make them safe. Which leads me to my conclusion. I think AI has really big potential for healthcare, and we might even need it to keep healthcare affordable. But few of these tools have been implemented, and I discussed a couple of pitfalls that really might contribute to this lack of implementation. I think we need to put our efforts and our focus on these pitfall areas to make sure that these models go from a great promise to actual safe implementation. That is my talk for now. Thank you so much. I really enjoy reaching out and talking about this topic. So please feel free to reach out as well. Happy to discuss. Thank you.
On, thanks so much. Very inspiring, and also, of course, words of caution, hopefully also at the very right moment. Then I think we take it together. We go to the next talk, Henock Yebyo. Maybe you just start up your talk, and then we will take all together.
Thank you very much. I'm going to talk about benefit-harm balance modeling for informed decisions. Decisions, it could be regulatory decisions, could be clinical guideline decisions, or decisions at the personal level. The decision could be it could be a regulatory decision, clinical guidelines decision, or personalized decision at a patient level. Okay, so my name is Henock Yebyo. I'm an epidemiologist from the University of Zurich. I'd like to start my talk with an example of tamoxifen for breast cancer prevention. I think it was originally approved for hormone receptor positive breast cancer, but later repurposed for prevention purpose, which is to prevent breast cancer. And tamoxifen has a clear benefit in preventing breast cancer, which is it can prevent about 97 breast cancer events out of 10,000 women treated over 5 years, for example. And tamoxifen can also improve the bone density and can prevent 1 out of 10,000. It's quite minimal. But it can also cause serious side effects, including stroke, vein thrombosis, endometrial cancer, or pulmonary embolism. In total, about, I don't know, about 60 events per 10,000. And there could be also other harm outcomes which are not reported here, mild side effects. Now the question is, can we give tamoxifen to prevent breast cancer for all women? Or are there any specific target groups who would derive a net benefit from tamoxifen, and how do we know it? I think that these such decisions are not clear, and they're not clear not only at the clinical decisions, but also at clinical levels and regulatory decisions as well. And you can also add that the outcomes, the harm outcomes, as you can see, are not of the same relative importance. Some of the outcomes are highly relatively important, others are maybe less important. And especially if you take into account the perspective of the patients, taking into account the experience, the illness, and the functional health of the woman, the relative importance of the outcomes could be quite different from person to person, from woman to woman. So there are no any systematic, I mean, I know that the clinicians, for example, could take into account implicitly about this benefit outweighing the benefit and the harms at an individual level. That there are no, what I mean is there are no any systematic structure benefit harm balance assessment methods either at the clinical level or at the regulatory level. And another example, I have a little problem here. I'm struggling, but it's showing me, okay, now maybe it's better. Okay. Yeah. Okay, another example is roflumilast, which is for prevention of COPD exacerbations. And roflumilast similarly has clear benefit. That is, it improves lung function and also reduces exacerbation. But it comes with mixed effects of harm outcomes, including nausea, diarrhea, headache, weight loss, dizziness, and others. As you can see, the harm outcomes seem to be mild or moderate, but when it comes to the experience, the daily activities, the functional health of the individuals, they might give a lot of discomfort for the individuals, and either they are going to abandon the treatment or they may not. If they have to take the treatment, they have to bear those side effects and giving an overall a negative impact on the health of the individuals. And the absence of any benefit harm assessment methods at any level of the decision context also leads to clinical guideline variations. For example, the most common treatment that is given for CVD prevention is statin initiation. And if you just look at the CVD baseline risk at which we initiate statins, they do really vary between guidelines and between countries. For example, in the US, they recommend to initiate statins as low as 7.5% CVD risk at 10 years. And in Canada, it ranges from 10 to 20%. In Switzerland, for example, 20 and 30 in South Africa, and it goes on. And this variation is because the evidence is very clear. We know that the way we make the recommendations either at clinical level or at the regulatory levels are quite different. We don't have any systematic and structured way of doing or defining the thresholds or defining the recommendations in general. And the variations additionally is because when we look at the low thresholds for the statin example, for example, in the US, those guidelines with lower thresholds were those developed by specialist cardiologists. And that means they are very much specialized, very focused on a certain efficacy outcome. And those with higher thresholds were generally developed by general practitioners. They are more close to the daily activities of the patients, so they take into account the different harms probably. And so in general, there could be many examples, but the point is that the interpretation of evidence is often incomplete and implicit. There could be implicit way of considering all the parameters that are needed in decision making, and we could implicitly make a benefit-harm balance, but it's one is cognitively difficult, but the other one it could lead to the variations at clinical level, practice level, at clinical guideline level, and regulatory decision level. And this is one. Most of the evidences they just focus on primary outcome, which is the efficacy outcome. If you have, you could have trials, but they are much focused on one outcome. They are optimized to detect the treatment effects of the primary outcome. They are statistically powered to detect the treatment effect of the primary outcome, but give less effect focus for the harm outcomes. And the way they do the sentence is also not optimal. You could have 20 trials or 30 trials, and you could try to pull the evidence, but they often pull the evidence just for one outcome separately, not pulling everything together and trying to assess the impact of the drugs, not just on one organ, one system, on one efficacy, but the overall impact on the individuals, on the functional health of the individuals. And there's always differences and not taking into account the subgroup differences and individual differences. So evidence generation, evidence sentence is often not complete, and it's often done implicitly and leading to discrepancy in regulatory decisions and clinical guideline decisions. So the benefit-harm balance approach could contribute to guiding informed decisions. And the point is that instead of just making a decision, taking into account one outcome at a time, we can take into account all the positive and negative outcomes altogether on a common scale, and we can outweigh the benefit against the harms and try to estimate the overall impact on the individuals. And all what we need is to consider all the negative and positive outcomes and try to estimate the absolute effects. And to estimate the absolute effects, we might have to take into account, of course, the treatment effects that we often get from trials or from any properly conducted causal inference from observational studies to estimate the effects, the relative effects. But because trials are not, they're optimized and statistically powered to detect the primary outcome, as I said, but they are not for the harm outcomes. So estimating the absolute effect of the harms from trials could lead to underestimation of the harms, because there's a big study participant selection, and the powers are not optimized to detect the treatment effect for the harms, and the duration of the trials could be too short to observe some of the harm outcomes. So it's often to take into account the treatment effect from trials, of course, but we have to also take into account the risk distribution for both the benefits and the harms from the target group or the population. And we can also take into account the competing risks depending on the target groups we have. If they're very sick or old age population, for example, the most common competing risk is mortality, or could be also others. We have to also take into account that. So with the baseline risk of the distributions in the target population, with the competing risk and the treatment effects, we can estimate the absolute effects with the treatment and without the treatment over a given time horizon we are interested in, depending on the context, and estimate the benefit-harm balance. And of course, as I said earlier, the experience of the patients towards the different outcomes, the benefit and harm outcomes could be different depending on the daily activities or the treatment goals of the individuals and experiences. So we have to take into account also the patient preferences towards each of the benefit and the harm outcomes. And this is also mathematically important because we cannot trade between one serious outcome versus one mild outcome. We have to take into account, we have to adjust the absolute effects by the relative importance of the outcomes. This is some analytical procedure, but I'm not going to dwell on this. The point is that taking into account the parameters, I try to discuss the treatment effects, the risk distributions in the target population, and the competing risk. We can predict the absolute effect for each of the negative and the positive effects. But for the prediction, we can apply any type of analytics that applies. It could be statistical models, it could be AI, or it could be machine learning in general, or it could be micro simulation, it could be other analytic approach that applies to a given context. And additionally, taking into account the preferences, we can then estimate the probability that the benefit outweighs the harms. And in this procedure, we do it random, using a random process, because we also take into account the precision of each of those parameters that are considered in this process. I would like to give some example from our previous studies. One is statin for CVD prevention, for example. And as you know, statins can prevent CVD, of course, that is the benefit, but they can also increase some risks, including diabetes, including renal and liver dysfunctions, myopathy, cognitive impairment, and others. So what we did was we tried to count the treatment effects, of course, from all available trials on the outcomes. We also considered the baseline risk for the outcomes and the preferences. And instead of assessing the benefit of the average CVD risk in a given population, what we did was we tried to estimate the benefit if the individual has low risk, medium risk, or high risk. So from 1 to 30%. What if an individual has a 1% risk of CVD? Does he benefit from statin or not? If it is 5%, if it is 10%, if it's 20%, if it is 30%, and so on. So as you can see in the distribution, you don't have to interpret it done, but 0 means it's a point of equipoise where the benefit equals the harms, or the net benefit is 0. A negative favors harm, a positive favors benefit. So for example, someone with 1% 10-year risk of CVD, he is less likely to benefit from statins. And that's because there's lack of the target point where the statins act. There's no any risk. But as long as the person takes statins, he will have the side effects. He's more likely to have the side effects. So then the net effect is a net harm. But as the baseline risk of the individual increases, then the benefit starts to be more beneficial than harm. For example, if the person baseline risk is 14%, for example, the net benefit is 0. If it is more than that, then the benefit outweighs the harms. So taking into account the baseline risks of the outcomes and taking into account the treatment effects and the preferences, we can try to identify which person is more likely to benefit from a given treatment. And this is just for one age group. But here I have for all age groups, 40 to 75. Actually, this is just for men. And as you can see here, we have baseline risks from 0 to 25. And for 40 to 44 years of age men, for example, someone having 4% or 6% or 7% is less likely to benefit from statins, for example. But when the baseline risk reaches 14%, then the probability of the gaining benefit from the statins would be higher than the harm. So it comes to green. And for the next age group also is the same. But for the 70 to 75, for example, the threshold to achieve a net benefit, it's about 21%. So as you can see, the risk threshold increases with age. So without considering the harms, you might think that the threshold should be either equal or maybe lower for older people. But it's because if we consider the harms, the harm distribution are much higher in the older people than the younger. So that counterbalance the potential benefit that they could get from statins. But this doesn't mean that all the people benefit less from statins. It's when they have to initiate. Otherwise, if we look at the average baseline risk in the older and the younger, of course, the older people would have higher average risk because age by itself is a strong predictor of CVD. We can also look at the statin types because the doses differ between statins, which could affect the potency, could also affect the efficacy and safety. So, for example, here we have the thresholds. Here is the threshold, it's around 14% for most of the statins, for atorvastatin, rosuvastatin, and fulvastatin, for example. But the point at which pravastatin could give more benefit than harm is much higher. It's only for high-risk people, and that's because it didn't have higher cumulative harm risks, but it was because its efficacy was much less than the others. And this is for tamoxifen. This is not our study, but so this is what they did was they tried to estimate the net benefits across the predicted 5-year risk of breast cancer, for example, by age. And as you can see, for 35 years to 49 years of age white women, they're more likely to benefit from tamoxifen. You just can see the intensity of the colors. Green means net beneficial, yellow means unclear, and red is net harm. So both age group can benefit at any baseline risk from 1.5 to 7.5, about 7. But when we look at the 50 to 57, they don't benefit when their baseline risk is below 4. But they start to benefit from tamoxifen when their baseline risk reaches 4 and above. And when we look at the older age 60 to 79, none of them could benefit from tamoxifen. And this is the same reason with the statins, because the distribution of the stroke, endometrial cancer, the DVT, and the other harm outcomes are on average much higher in the older people, which offset the potential benefits they could get from tamoxifen. But you can also think that what if individuals, the women do not have uterus, if they underwent a total hysterectomy, that means they will have less risk of cancer, for example, and their probability of benefit from tamoxifen will be higher. So we have to take into account the baseline risk of a specific woman with regard to the harm outcomes and with regard to breast cancer, and we can try to personalize, we can try to tailor the treatment towards each subgroup or each individuals. And this is just for white women, but the benefit also is different for as compared to black women, because there's a risk differences between white women and women. White women has about 2 times higher risk of fracture endometrial cancer, but black women have also 2 or 3 times more, much higher risk of stroke, pulmonary embolism, and DVT, which really results in differences in risk thresholds at which we have to initiate tamoxifen. Okay. This is another study from Netherlands we did on CRC screening. In Netherlands, starting from 2024, CRC screening based on the FIT was implemented, where in all adults 55 to 75 years old, and those who are positive on FIT are referred to colonoscopy. So clearly the benefit is reducing CRC risk and CRC mortality, but the harms are false positive, false negative complications. Complications are not a complication of FIT, but a complication of those who are referred to colonoscopy. So risk of bleeding, risk of perforation, and other pain, for example, and other harms, as well as test stress. So what we did was we tried to estimate the predicted risk using microsimulation over 10 years, 20 years, and 30 years, depending on different patient profiles, and try to estimate the benefit harm balance, which age or which sex would drive net benefit from CRC screening. And what we found was the net benefit of the fit screening was much pronounced over a longer time period, and which makes sense because in the beginning, the harm outcomes occur right away during the screening. If it is false positive, if it's false negative, if it's complication, those happen while we do the screening. But the benefit comes much later. After 5 years after screening, for example, we don't see any difference in terms of CRC incidence because it takes about, on average, 25 to 30 years to develop the adenomatous cancer level to be detected. So we don't see any differences in cancer incidence in just 5 years or 6 years, but we observe much differences when it is 20 years or 30 years. But there's a little interesting result here as well in the 30 years where the net benefit, although all subgroups were on average could drive a net benefit from screening, but relatively, when you look at the probability, it slightly decreases over time. And this is because the older people will run out of time because they will they should live. For example, for someone who is 71 years old, they should live about up to 100 years to achieve, on average, the benefit of CRC screening, and that's why the net benefit relatively decreases. It's because the life expectancy at the present age will be much less. This is same for ICS for COPD exacerbation, GLP for weight reduction, but I would like to just focus on another point which I didn't explain yet, which is preference sensitivity. So far, I showed you results where we used aggregate preference values towards the different benefit and harm outcomes. But as I tried to explain earlier, the experience, the illness to individuals, the treatment goals, the functional meaning to the different patients could be different. So we can assume, we can test that whether the benefit harm balance are preference sensitive, depending on the preference range between individuals. And for some of the outcomes, of course, they really affect the benefit harm balance greatly, but for others, no. For example, if the absolute effect is much larger, the preference towards that outcome could be really affecting the benefit harm balance. There could be a big range of net benefit between individuals. But if the absolute effect is very small, for example, rhabdomyolysis for statins, we don't see any difference. It's the same. But for diabetes, because diabetes has the statins is associated with considerable amount of number of absolute effects, excess absolute effects in diabetes, the preferences towards diabetes showed a relatively spread net benefit between individuals. But this is an ideal range between 0 and 1, and we don't expect individuals to assign 0 for diabetes. Maybe the reality could be between 0.2 or 0.5 something. So, but even then, the range of the thresholds, according to the variation between preferences among individuals, could really lead to preference sensitive benefit harm balance. So if our benefit harm balance shows that they vary between individuals, that means that our decision should not be based on aggregate results. Rather, the decision should be personalized to individuals. So we have to take into account the treatment effects, of course, from the evidence available, but we can take into account the baseline risk for each individual, not subgroup, stratified subgroup or population level, but just for a specific individual. And also take into account the preferences of the individuals and try to estimate the benefit-harm balance tailored to an individual patient. And this can be done using a decision aid within the framework of the benefit-harm balance. This is an example where we are doing in the obesity cohort using the GLP treatment for weight reduction, what we did was we tried to assess the benefit-harm balance and its preference sensitivity, and we found that the decisions are preference sensitive. If individuals are willing to accept the harms or they're risk averse, then the benefit-harm balance really differs very greatly. So the implication is that instead of making decisions and using the aggregate evidences, we can tailor this to an individual level decisions, and this is something that we are trying to do currently. Yeah, that's it. Thank you very much.
Henock, thank you so much. Really illuminating. I realized that you have extremely sophisticated tools, opportunities, possibilities, which are highly interesting for the clinic, specifically also to sarcoma care. But I realized that you really depend on the input data. That's really fascinating. I suggest that we just move on to Lucia Petito, talking about the target trial emulations.
Thank you so much for inviting me to speak today. My name is Lucia Petito. I am an assistant professor in the Department of Preventive Medicine at Northwestern University. And in my training, I am a biostatistician, and I also work quite a bit in epidemiology. So today I'm going to be talking briefly about target trials. Don't worry if you haven't heard of target trials before. I will define that for you. But broadly, we'll be talking about causal inference and observational data sources. And I will walk us through an example using SEER Medicare data for comparative effect. So just so we're all on the same page, because I know we've been talking about a lot of different topics this morning. When I talk about causal inference, I am really talking about scenarios where we are interested in estimating the causal effect of a particular action A on an outcome Y. And really, in science, everyone wants to do it. So in the hard sciences like biology, chemistry, physics, or engineering, people primarily use experimentation for causal inference. My husband is an organic chemist, and as he tells me, if he runs the same reaction at two different temperatures and he sees a difference in the yield of the reaction on the other end, he can directly attribute that difference in yield that he sees to the difference in temperature that he had specified himself. But in the soft sciences, I'm going to roughly call that epidemiology, public health, economics, or sociology, we often aren't in scenarios where we can have such tight control over the experiments that we're doing. And so we often turn to observational data sources in order to draw causal conclusions about the world around us. So I always include this caveat when I give talks about causal inference, which is that while causal inference encompasses many of the questions that we're interested in answering, not all questions are causal. So examples of causal questions include things like, does liver transplant surgery increase the life expectancy of individuals with cirrhosis? But examples of non-causal questions are things around, counting. So how many people in the United States have early onset dementia would be an example. So our motivation here, and I'm sure your motivation, is how do we make decisions in medicine? Should I prescribe drug A or drug B as first-line chemotherapy to extend my patient's expected life? And when we think about making decisions, many of those questions that we're interested in answering can be answered using a well-designed randomized controlled trial. And I'm sure in your training, you're very familiar with that lovely picture of a pyramid, and that little tippy top of the pyramid is usually meta-analyses of randomized controlled trials. And so for a long time in medical education, people have really emphasized that the only place where we can draw well-reasoned causal conclusions around medical decision-making is from randomized trials. That said, there are barriers to conducting randomized trials. So they can be quite expensive. Maybe this statistic is even a few years old now, but on average, conducting a reasonably sized randomized trial will cost upwards of $10 million US. A lot of the time, we may be interested in studying long-term outcomes, and it may take a long time in order to do that. So an example would be in studies for strategies around the timing of colorectal cancer screenings. It takes a long time for colon cancer to develop in some scenarios. And so in order to observe sufficient events in each of the arms, the trials need to go on for a long time. The last is sometimes it's just unethical to conduct a randomized trial. So I'm sure many of you believe that smoking causes lung cancer, but that evidence actually all comes from observational data. There has never been a randomized trial to randomize people to smoke or not. So what we do instead in these scenarios where we can't run a trial is we want to use observational data in order to answer our questions. So there's kind of two categories of this. The first is what I'll call, classic epidemiologic studies, including cohort and case control studies. Those aren't my focus. What I tend to focus on is what I'll call found data, which is data that was not initially collected for research purposes. This includes things like electronic medical record data, administrative claims databases from insurance companies, or things like national registers, which we are not fortunate enough to have in the United States, but you have lots and lots of in Europe. So the big picture when we are using observational data, found observational data, is that we want to be able to conceptualize our observational study as a conditionally randomized experiment. And a caveat, and I will repeat this ad nauseum, but these secondary data analyses are not our preferred choice. We of course would prefer to run the randomized trial, but that's just not possible in all scenarios. So why do we need to spend so much time thinking about how we design our observational studies? So I'm going to go through two examples here. The classic example is about hormone replacement therapy in postmenopausal women and risk of coronary heart disease. So the Women's Health Initiative is a big study, and I apologize because I'm not a medical doctor, but it was a massive initiative funded by NIH in the mid-1990s. I want to say they must have spent over $200 million on Women's Health Initiative. It was a randomized experiment, randomizing women to receive hormone replacement therapy or not. And it was stopped early because at an interim analysis, they found a 20% increased risk of coronary heart disease in initiators of hormone replacement therapy compared with the non-initiators. And so then there was an observational study done everybody was very disappointed about this because they had spent a whole bunch of money. And so some researchers at Harvard went into the Nurses' Health Study, which is a longitudinal cohort study based in New England. And they saw in their observational study that there was actually greater than 30% decreased risk in current users of hormone therapy compared with never users. And so this threw the, field of epidemiology into a tizzy a little bit, because people were throwing their hands up and saying, well, if we're not able to replicate what we saw in this randomized experiment in our observational data, why are we using observational data at all? We should just stick to randomized experiments and, stop the observational studies. And they attributed their inability to get similar results to unmeasured confounding, is what they said. They said, oh, well, we're just unable to control for confounding in this scenario. So a few years later, this is in 2008, there was a reanalysis of that same data from the Nurses' Health Study, but this time to compare incident users of hormone replacement therapy versus non-users. And when they performed this reanalysis of the Nurses' Health Study, they found similar estimates to the initial Women's Health Initiative findings. So from that randomized control trial. So this is just, it is very important for us to be precise about what question we are asking from the observational data source, because how we define the variables that we use in these observational analyses actually can make a really big difference in the results that we see in the study. So another example of this is in statins and cancer risk. So in January 2006, there is a paper published in JAMA that is a meta-analysis of randomized trials only, and it found no cancer mortality benefit to statin use. With I'm going to call that a very null finding, an odds ratio of 1.01 with a 95% confidence interval of roughly 0.9 to 1.1. That is a very null result, in my opinion. That being said, after 2006 and the publication of that meta-analysis, flawed observational studies continued to happen. And all of the studies in this table here, I can turn my laser pointer on, right? So all of these studies were published after 2006. And they were all flawed in different ways. Some of them compared all statin users to non-users, and they found, a 60% risk reduction. Prevalent statin users versus non-users did a little bit better, but still, this is, demonstrating about a 20% reduction. And then mixing prevalent and incident statin users yielded a hazard ratio of 0.7. So in this scenario, Dr. Miguel Hernan's group at Harvard did a reanalysis of the SEER Medicare database, which I'll talk about in a moment here. And when they reanalyzed the SEER Medicare data to compare incident versus non-statin users within 6 months after cancer diagnosis, they found that there was a null effect, no improvement of 3-year cancer-specific or overall survival. So these are just some examples of how it's really important to spend our time thinking about what is the question that we're actually asking in our observational data source. So I think one of the first talks I ever saw Dr. Hernan give he put a slide up that was just called his two-step algorithm for causal inference. And it just had step 1, ask a causal question, and step 2, answer that causal question. And really that is quite a simplistic way of putting things, but it does actually break down how we think about designing observational studies, designing comparative effectiveness studies in observational data sources. So the first thing we do is we think about our thought experiment. We imagine the hypothetical randomized trial that we would prefer to conduct and analyze, and we call that the target trial. Now, this doesn't have to be a real trial that existed in the world. It's just the trial that would answer the scientific question that you are interested in asking. Once you've done that, you have a choice. You can either go into the world and secure funding to conduct the target trial, right? This hypothetical randomized trial, or you can analyze found data as an attempt to emulate that target trial. With, of course, the caveat that we can never hope to emulate a tightly monitored, placebo-controlled randomized trial using observational data. We really try to emulate pragmatic trials instead. So what does the design of the target trial look like? Well, it looks like just defining all the same things that you would define if you were going to design a randomized trial. You need who will participate, so eligibility criteria, what you will do to them, so the treatment strategies that they will be assigned to, how they will be assigned, and what you're going to measure about them, the outcome. You need to know when you're going to be doing all of these things. So when will you start following people and when will you stop following people? And then the how, right? So what is the causal contrast of interest that you're interested in defining? And how are you going to be conducting your statistical analysis? So when we do a target trial, we do that analysis in found data. And so we always have a table that specifies exactly what the target trial is, the hypothetical trial that we'd be interested in conducting. And then we have to be very clear about the limitations of our found data sources. So how is our found data not going to be able to what are the limitations associated with that found data source in answering that target trial question? So just one thought about target trials broadly is they have gained a lot of popularity in the last few years. I think when I did a Google Scholar search last month, the phrase target trial turned up like more than 8,000 results in the last decade. And I think part of the reason for this is that it's a really nice tool because it bridges the communication gap between medical researchers and people who are kind of more on the quantitative ends of things. And one of the nice things about this framework is it really clearly outlines places where we need to add sensitivity analyses to investigate the robustness of the results, the results that we get at the end of the day. So moving on, I'm going to go through a brief example here from a paper that was published, I believe, in 2020 or 2021. So when I was a postdoc with Dr. Henock, we were contacted by the National Cancer Institute because they were receiving a lot of requests to conduct comparative effectiveness research in the SEER database. So SEER stands for Surveillance Epidemiology and End Results. It's a database that contains information about the demographics, tumor characteristics, and some genetic factors for cancer patients in the United States from many states. I want to say something like 27 or 28 states. You know, Dr. Hernan's first response to NCI was that, well, that's just fine, but SEER by itself doesn't actually contain enough information to conduct the target trial because there isn't detailed enough information about treatment history or the comorbidities that the patients might be experiencing. And so they said, okay, well, what about our linkage with the Medicare database? So Medicare is the health insurance program in the United States that serves our elderly population. So individuals age 65 or older. And Medicare claims contain detailed information about treatment history, comorbidities that the patients might be experiencing, as well as any alternate therapies they might be taking. So of course, in this database, we still have some unmeasured confounding. Of course, it's claims data, so we cannot capture physician judgment or patient preferences towards the treatment. But we think that there's probably enough data available in the SEER Medicare linkage to really get at the detail around the cancer diagnosis as well as the treatments that the patients actually underwent. So the question that we outlined was, how can we know whether SEER Medicare can be used to answer comparative effectiveness questions? And so our thought there was we might benchmark to an existing pragmatic randomized trial. So again, caveat that I'm not a medical doctor, but we did an analysis for treating stage 2 colorectal cancer. And importantly, what we saw is that in the elderly subgroup analysis from this trial, there was a null result, comparing fluorouracil-based chemotherapy to placebo. And in the subpopulation here, subgroup for people ages 70 years or older, the hazard ratio was 1 with a fairly wide confidence interval. So we went back to our SEER Medicare database and we decided to emulate this trial. So on the left here, we defined who would participate in the trial. And of course, we based this off of the Quasar clinical trial that was already going. Let's see. What we see here is that we were interested in enrolling individuals with a diagnosis of stage 2 colorectal cancer who had had a complete resection of that cancer with uncertain indication for chemo. We wanted them to have no history of prior cancer, no prior chemotherapy, and we needed them to be enrolled in Medicare for a long enough time to make sure that we would have sufficient data on them. In our emulation, if a patient had multiple records of surgery, we used the first record. We would have randomized them to one of 2 trials to initiate fluorouracil as first-line treatment up to 3 months after post-surgery hospital discharge, compared with not initiating any chemotherapies within that 3-month period after discharge. And in our hypothetical trial, we would leave the decision to discontinue fluorouracil to the physician and the patient. And we said that patients could receive any additional therapies to supplement that fluorouracil. So in our emulation, that's exactly the same. And we assumed that any claim for chemotherapy after that grace period, that initial 3-month period, was assumed to have been clinically indicated. Our outcome was death from any cause certified by a physician, reported to Medicare, and confirmed by the National Death Index within 5 years of the beginning of follow-up. And here's one place where the target trial necessarily differs from the emulation. So in our hypothetical target trial, we would want to have randomized the patients to one of the two treatment strategies at baseline. But of course, we're not able to have randomization and observational data. So we emulate that by adjusting our estimates for baseline confounders, which we have to think about in great detail. And one of the strengths of SEER Medicare data, again, is that there were very detailed tumor and surgery characteristics available, as well as comorbidities. We followed them beginning at their discharge after the initial surgery to remove the tumor, and follow-up ended at the earliest of death, loss to follow-up, or administrative end of follow-up. I'm going to skip this for today because I know I'm running out of time here. So at the end of the day, we identified 9,549 eligible individuals for our target trial. Of those, only 204 initiated the fluorouracil within the 3-month period that we had specified after their hospital discharge. And fluorouracil initiation was more likely in younger married individuals, those with diagnosis of rectal or both rectal and colon cancer, and T for tumor stage, so bigger, more advanced cancer cases, which makes sense. And it was less likely in individuals who had a prolonged hospitalization after surgery, those who maybe were a little bit more fragile, so they had anemia or asthenia in the year prior to diagnosis, or those who had preoperative radiotherapy. So we saw here that we estimated that a 5-year risk difference of about -4% with a confidence interval of -15% to +13%, which I would call a pretty null result, which, remember, we were trying to benchmark to that initial quasar study. I would say that these are compatible with each other. They're, again, we wouldn't expect them to be identical because they're from 2 different samples. But the change in direction of the hazard ratio is probably not meaningful in this scenario. And we did see quite a difference in the estimate of the 5-year survival. I read these numbers off of the survival plot from the initial quasar trial. But in general, the quasar study was much younger than the SEER Medicare database. And so we think that's probably where that difference in risks actually comes from. So I would like to acknowledge the funding that was used to support this work from the National Cancer Institute, and thank my wonderful collaborators. It was a great experience working with all of them. And I will just leave you with a couple of thoughts here, which I hope that you could take away a better understanding of the target trial framework and how we use it to think about our design of observational comparative effectiveness studies. This idea of benchmarking analyses to publish randomized trials really gives you an idea of the quality of your data analysis. Big data is not always as big as we think it is as the other one. So I guess thank you very much for your time and attention. And I guess we'll actually probably take questions after the last talk here.
Well, thank you very much, Lucia. It's really opening up the spectrum tremendously. I suggest that we have Philip now presenting his talk.
Right. So thank you very much. My name is Philip Heesen. I'm an MD and MSc statistics student from Zurich in Switzerland. And I've been working together with Bruno and the Swiss Sarcoma network for over 3 years now. And today I want to talk about the way that we at the Swiss Sarcoma Network try to reach the goal of individualized precision medicine. We've heard about 3 different and very fascinating methods, statistical methods that we can use to do causal inference and derive treatment strategies. But of course, all of these need data, and they need good data. And we all know that collecting data, and especially documentation of a patient's consultation, is a struggle, mainly because it takes too much time. There was a study conducted in 2018 that shows that actually 35% of a physician's time is spent only with documentation. And of course, that's not just all of the time that doctors spend on administrative work. Furthermore, there are so many different forms to fill out, but not only that, but they often collect the same thing. So you have to fill something into a hospital system, and then at the end, if you want to do research, you have to fill something into a data collection form, into an Excel or SQL database. And if you do these data collection forms are most often than not disease specific, and they're not flexible. So if you are a sarcoma expert, you might want to collect different kind of data than someone who works as a cardiologist focusing on heart failure. And if you collect data, then it always requires an even more cumbersome step, which is data cleaning. So I want to show you the SSN approach, and this is the figure that I want to use to guide you through the process today. The first one is Physicians Admin Ally, which I'm going to talk about, which is a tool that should help you easily and efficiently collect data in a way that is useful for your daily clinical practice, but also in a way that's useful for you to do research. And it should help you decrease administrative time in order to ensure that you can spend as much time as you can with your patients. The next is the SAR connector, which essentially consists of 2 parts, which is a data warehouse, which is interoperable and is an SQL database, and which is stored at the ETH University in Zurich. But it's also composed of multiple web apps, which in real time automatically analyze data and help you derive meaningful conclusions from these data. The SAR connector is used in order to reach the goal of value-based healthcare. And I will show some examples of work that we have done in the field of value-based healthcare. And the next point is integrated precision health analytics, which for us consists of 3 points, which are the research pathways that the SSN is currently exploring. And we've heard about these topics today, which is predictive analytics or clinical prediction models using AI, which Anna has talked about. Then benefit harm modeling, which Henock has talked about, and then Lucia has talked about target trial emulation. And we want to use all of this to create a sarcoma digital twin, which is an individualized collection of data from the patient and from their tumor, which should essentially help us to make personalized treatment decisions and then ultimately, hopefully, reach precision medicine. So the Physicians Admin Ally, which helps you collect data, consists of 3 parts. The first one is the Patient Pathway Explorer. In the Patient Pathway Explorer, you have the SSN Registry, which is a web app which interactively guides you through the data collection process of a patient. This is currently being used for sarcoma board presentations at the Swiss Sarcoma Network. You can fill in, as you can see here at the top, you can fill in personal data, clinical data, data about the sarcoma board, which you can see here, about radiology exam, pathology exam, and then the 3 different treatment strategies: surgery, radiotherapy, and systemic therapy. And it guides you to collect all of the most important data. For example, the date of sarcoma board, the question asked to the sarcoma board, whether the last sarcoma board question actually was, or the last sarcoma board decision was executed, and if not, why, whether it's due to a different, opinion of the physician, or whether the patient did not want to go through with this decision made by the sarcoma board. And it helps you easily get through the data collection in clinical practice, and hopefully it can reduce your the time that you have to spend on collecting data. And the second part is the is PROMS, which is patient-reported outcome measures. This is a web app that we have created. It's in German at the moment, and it allows you to give this form to a patient either before the consultation or send it out to them by email, and they can fill in this questionnaire. In this case, it's the EQ5D questionnaire. They ask about their mobility, whether they can take care of themselves in daily life, their activities, pain, psychological problems, for example, anxiety. And this is a tool that helps you collect these PROM data in an easy way, either by email or before the consultation. So to summarize, the Patient Pathway Explorer uses the click and collect principle. You can click on different options. You can choose from different options and then collect the data. The advantage is that it leads to standardized data collection, and it also ensures completeness of data. And the tool that we have created is very specific for the sarcoma patient pathway. So if you're a sarcoma expert, this should answer all of the questions and all of the data that you want to collect for your patients. Then the next thing is LingoLink. LingoLink comes with the topic of taking time for things that really matter. It's speaking to patients rather than writing about patients. The LingoLink is a model which does transcription for you of the patient-physician conversation. It actually listens to you speak to your patients. And then rather than just transcribing this into words, it summarizes this for a physician's report, for example, and can be used for very different kinds of reports, filling in certain fields in your hospital system, or even an entire doctor's report. And then there's the Med AI Harvester. So in most hospital systems, if they're electronic, physician notes are stored in PDF documents. And it's very difficult to use these PDF documents for research, because you essentially need structured data. You need, for example, an Excel sheet, you need an SQL database, and so on. So the Med AI Harvester is a validated ontology tool, which helps you to use all of the PDF documents, combine them, and derive structured data that you want to use for your research. And using this structured data, you can then come to your study results. And the fact that this actually works, the Med AI Harvester, has been shown by Alexander, who's also on the panel today, and he's just published his article, which is in press at Nature Medicine, showing that this framework actually works. Then moving on to the SAR connector. The SAR connector has been built at first with the goal of looking at quality of care for sarcoma patients. And we have published this article in Cancers, where we have shown that longitudinal real-time assessment of quality indicators actually works. First of all, an expert panel of sarcoma, international expert panel of sarcoma experts and sarcoma physicians have come together to define quality indicators. And we have then used the data that we have collected using the different tools, and especially the Patient Pathway Explorer, and created a platform which automatically in real time analyzes these quality indicators. And we were able to show that if you collect data on quality of sarcoma care and look at this in detail, and this is exactly what's being done by the SAR connector, gives you the results in detail and in real time, you can actually improve sarcoma care. And the nice thing about it is that you get feedback of measures that you might have implemented in real time. So you will know very soon if you went down the right path with the measures that you have chosen or not. This is a screenshot of the web app. These are two different quality indicators. And this web app visualizes and tells you the results of these quality indicators for different hospitals, for patients that have WOOP zone unplanned, excision, for patients that have certain dignities, only for benign patients, only for malignant patients, and for different timelines. And this is one of the quality indicators depicted at the bottom, which is the time from biopsy until its establishment of diagnosis. And here you can see a box plot, and along with this, the summary statistics showing that in the time period from beginning of 2022 to the end of 2023, the median was 5 days, ranging from 2 to 9 days as the interquartile range. And at the top, you can see the decisions that were made on therapy. You see most decisions were made on surgery and then chemotherapy and radiotherapy, and derive information from these figures. And because we were able to show that using this tool, you can actually improve quality of sarcoma care, we have received the German Medical Award in 2021 and the CSS Quality Crystal Award in 2022. The next thing, which is also part of the Patient Pathway Explorer and which helps you collect the data and then can be analyzed using the Sarconnector as the prompts. And again, we have created an interoperable digital platform to help you analyze the prompts. And we were able to show that you can actually achieve longitudinal structured real-world time data evidence analytics using this. This here at the top is an example of this longitudinal assessment. Here you can see the functionality score measured using the EQ5D PROM. And this specific patient had so far has had 6 consultations. They filled in the EQ5D 6 times. And at the second time, they had a biopsy. And then at the third visit, they started chemotherapy consisting of busulfan and melphalan. And then probably as expected, their functionality score decreased a little bit. And after these cycles have been discontinued as planned, the functionality score again increased, which can be seen here. But then at this consultation, unfortunately, they were told that they developed bone metastasis. So probably knowing this and along with the metastasis developing, their functionality score decreased again. And at the bottom, you can see the radar chart of a specific patient. And when the patient fills in the data before the consultation, then before they come into the room to talk to the physician has the chance to quickly glance at this radar chart and see what problems this patient might have. So this is in German, but this patient does not have any problem. They have full points when it comes to taking care of themselves. And also full points, so no problem with anxiety or psychological problems. But this patient specifically had problems with mobility, with usual activities, and with pain. So as a physician, you now know which areas of the patient's daily life you might want to talk about and spend more time at to really ensure that the patient can talk about the things that they want to talk about and the things that they concern them the most. Moving on from the Sarconnector to a few examples of how we wanted to work on, or how we worked on value-based healthcare. This is an overview perspective paper that we have recently published, which shows you how we are creating the Sarcoma digital twin to help with individualized treatment decisions, how we are using AI algorithms, digital health, and how we want to go about achieving precision medicine. And to get into more detail, we have looked at benchmarking, and we believe that benchmarking is really important because it helps you derive useful information and it helps you identifying areas of improvement. Again, healthcare providers can thus optimize their resources, improve patient outcomes. In this specific study, we have compared 2 sarcoma boards and the decisions that they have made. And we found that in one sarcoma board, which is location-wise very close to the other sarcoma board, they have used a lot more chemotherapy in their patients. And now this can raise the question what the indication was for using more chemotherapy and how these differences might arise. Another project that we have just finished is looking at the diagnostic interval. And we have taken the diagnostic interval and looked at different parts of it. And we have found that, interestingly, the patient and the secondary care interval represent the bottlenecks. And these are the times that take up the most of the whole diagnostic interval, which is actually defined as the interval from the first date of onset of symptoms to then making the final diagnosis. And the patient interval is the interval from the first date of symptoms to the first consultation with the physician, while the secondary care interval is the interval from the first secondary referral to the referral to sarcoma specialist. And we can now see that these might be areas probably easiest to work on secondary care interval. and that this is something that we can work on and see that there are certain factors that actually had a great influence on these intervals, which were age, grade, localization of the tumor, and the size of the tumor. Now moving on to integrated precision health analytics, and an example of a project that we are currently conducting that uses target trial emulation. And we are looking at the impact of a whoops sarcoma resection, of an unplanned sarcoma resection. This is interesting because over 20% of all sarcoma patients get their diagnosis after a whoops operation. And our hypothesis is that whoops patients have a worse outcome and a higher burden of disease because they might need more interventions. They might need adjuvant radiotherapy, maybe adjuvant chemotherapy, than patients who had a planned sarcoma resection, hopefully a wide R0 resection. So the study design is to emulate an RCT by conducting a target trial and comparing patients that had a whoops operation versus those that did not have a whoops, not have an unplanned resection. We have defined as the time zero, the date of first interventional operation, and we are looking at different outcomes, which is overall survival, local systemic recurrence, the duration of operation and reoperation, complexity, and treatment costs. And just a primary, or just one of the results that we are currently looking at is how many patients were actually reoperated after whoops. And there we can see that there are certain patients who were not being reoperated, 28%. And then looking at benefit harm modeling, we are looking at the benefit and harm of using neoadjuvant chemotherapy in patients with a soft tissue sarcoma. And the group by Gronke et al. Have suggested that the circulator, which is a clinical prediction model that they have created, can be used to derive the indication for neoadjuvant chemotherapy in patients with a soft tissue sarcoma by stating that if a certain threshold of probability of death has been passed, that then these patients probably do benefit from a neoadjuvant chemotherapy. But rather than just looking at benefits, we also want to look at harm and calculate the benefit-harm ratio, as has been very nicely described by Henock. And we are expecting this curve. We're expecting to see that patients with a low probability of death do probably not need neoadjuvant chemotherapy, but then as the probability of death increases, they probably do benefit from neoadjuvant chemotherapy when subtracting the harms from the benefits. And then after a certain cutoff or after a certain peak, these certain patients might not benefit anymore. Maybe because even out doing neoadjuvant chemotherapy or any kind of chemotherapy might not help these patients anymore. So these are my take-home points. Collecting data is very important in order to use these great tools that we've heard about today, whether it be clinical prediction models, benefit harm modeling, or target trial emulation. But it's very important that data are collected in an easy and an efficient way without, and this is very important, without increasing the administrative work for physicians and for the whole team. And this is the first step towards precision sarcoma care. The Physicians Admin Ally, which is our tool, which soon will be launched, should lead to keyboard liberation, which should help you as a physician spend more time talking to your patients rather than writing something about them in a doctor's report. Especially in sarcoma, international collaboration is needed. So if you're interested, please participate in our study, which addresses the impact of unplanned sarcoma resection. And to actively collaborate, which we would be very delighted about, please contact Professor Bruno Fuchs under the shown email address. This is again our SSN approach, which I've guided you through today. And with this, I want to thank the Swiss Sarcoma Network and the Sarcoma Academy, and of course, the great speakers today for the highly interesting presentations.
Thank you very much, Philip. I know time is very much advanced, and probably it's if Gerard is still among us, I think I don't want to get around to ask him a question about his impression. I think we have tremendous tools available. Maybe switch the screen that we see each other again. We have tremendous tools available, but the data input is and remains a challenge. And I want to ask Gera what, let's say, his own approach is and how he judges what he heard today.
Well, thank you. I hope you can hear me, because interested in the last presentation, the Sarconnector work is quite interesting. A question that comes up is because I think the approach is quite nice and important for sarcomas, being such a rare disease. But Switzerland is a small country with not too many patients, hopefully, for sarcoma.
Exactly.
Is there already some international collaboration? Because that is what we need, I think, to get enough data for the specific subtypes of sarcoma. It is,
yeah, that's a great and really important question, I think, and we are currently working on international collaboration, and we are also hoping to use this webinar to get people interested into our approach and to hopefully collaborate with us to join our efforts. And as I said, we'd be very delighted if people come up and say, yeah, we want to actively collaborate, and we are pursuing different ways of actually ensuring that international collaboration, which is so important, can be done for our projects here as well.
Yes, we at SPAN, the Sarcoma Patient Advocacy Global Network, are also very interested, of course, in what patients experience wherever they are in the world. We are trying to connect to as many patients as possible, and we also see that there are, especially after the digital revolution, we have so many social media and possibilities for patients to connect and exchange their experience. As a board member of SPAN, my ambition is to really try to connect to as many patients worldwide as possible, and hopefully with some kind of open source platform, rather than using one of these commercial networks like Facebook. Because we run into all kind of problems and questions with using those, but that's what people have and what are people mostly using right now. I've been working on also with people at the University of Leiden and other researchers to develop artificial intelligence methods and natural language processing to get the let's say the prompts that you are registering at your hospital in a structural way. People, when they talk to other patients, they are talking about everything that they experience. So it's a very rich source of what they experience in terms of anxiety, in terms of side effects, in terms of what they do about the side effects, the strategies to live with it. So I think this could be a very rich addition to the work you are doing in the hospital. But we still have to go a long way to get enough patients participating and enough data to be of value. But this is certainly the way to go.
Hera, we recently exchanged in Dublin, and I really admire what you do. Maybe take a minute to explain also, how you use the AI approaches to harness data from the Facebook, and how many patients you can target through this open way.
Yes, well, in particular, I've been working with a group, a patient forum for GIST patients, and as you know, GIST is the largest group within the sarcoma family. And on this group, we had in total 6,000 patients participating, which is quite a lot. And we used the discussions to find in particular side effects using also AI. So we trained. And in this respect, referring to the first presentation we heard from the University of Utrecht, there I think it was mentioned, or it was also stated that you can have problems in AI in terms of a bias, but this all depends on the data that you have available to train your algorithms. So it is very important when you use AI for sarcoma that you have sarcoma data and patient data, sarcoma patient data to train your algorithms. And that's what we have done for the GIST patients. And in order to train the AI algorithms, you need also experts to find the specific discussions. Where do people speak about their side effects? That's not a very clear thing. So you need. So we have used patients to help us to annotate discussions. So you have to say, okay, this sentence is about a side effect. This sentence is about a side effect. And then you can, if you do that for, let's say, a couple of hundred sentences, then you can teach the algorithm to find side effects themselves. Or the algorithm must be able to find the side effects. So that's how we worked.
Yeah, I really like this point.
And the challenge is to get discussions, to get as many patients as possible to take part in these discussions.
Yeah, I like your point, because I think that Henock has said today that it's very difficult with RCTs not being conducted for such a long time and the follow-up not being so long, that it's difficult to actually estimate the harms, and that sometimes they can actually get wrong estimates. But at the same time, these are really important for benefit harm modeling. And that's why I think that's such a great initiative that you take to use AI and derive what the harms and what the side effects were for some people.
Yeah. And put the whole thing together. I think there's still a lot of work to do. Gerard, thank you very much for sharing your experience in the end, very briefly, but there are still quite a few participants here, considering there are already 2 hours that we spent, but it shows how important it is and how much energy we have to dedicate to this aspect in the future. I thank you all, the speakers, very much for your contributions to really show the future of sarcoma care. And I think for me, the most important message was in the end by Gerard. We have to move together. We have to bring the patients together. And we have to get specific data on sarcoma to be able to train the models in the future. With this, thank you very much. I think it was very exciting. I wish you happy holidays the rest of the year, and hopefully to see you again in the new year 2024. Thank you so much.
Thank you.